All right. Hello, hello. Hello, everybody. Good to see everyone today. I will give you all a minute to get connected. It is a wonderful day to get back together. We have another great presentation for you today. While you're all getting connected, just gonna go ahead and ask you all to open up your chat box, give us a shout out, let us know where you're coming from. In case you might be one of the rare few that haven't done a lot of Zoom calls, although I think we're all experts at Zoom at this point. Just hover over at the bottom of your screen. You'll see the little chat feature and you can click that and open up your chat box and then give us a shout out. Tell us where you're joining us from. And then also there's the closed captioning if you like that. Sometimes it's helpful to be able to read also what's being said. It's transcribed as we speak, but if that's distracting, you can remove that by going to the closed captioning or the live transcription button and clicking that and then going to hide subtitles, and that will remove it. You can also put it back if you decide, hey, you know what, I kind of would like to have that. So I want to kick us off. My name is Anissa Mitchell and I'm with PMD Alliance. I'm so glad that you're all with us today. And joining us is our speaker, Joan Miravite. She is a nurse practitioner who serves as director of the Interdisciplinary Clinical Care and Movement Disorders at Mount Sinai, Beth Israel in New York City. And she's going to be talking to us about deep brain stimulation. We are going to allow you to both chat and unmute yourself for question and answer time, but that will be at the end of the program. So when she's done with her presentation, if you would like to ask her a question directly, we will give you the ability. The only thing we ask is so that we know that you want to ask a question, if you would raise your hand by utilizing your reaction buttons. Also, if you click up on the participants, you can see there's a little the buttons there. There's a way for you to raise your hand there as well. So please just notify us so we make sure that we know that you want to ask your question. So I'm going to pass this off to Joan. Joan, thank you for joining us.
Hi, thank you for having me. So just a little introduction. I'm going to be speaking today about deep brain stimulation and programming. So my name is Joan Miravite. I'm a family nurse practitioner and I have a doctorate in nursing practice. I'm an assistant professor of neurology at the Icahn School of Medicine at Mount Sinai. I'm lucky to be a center coordinator for the Parkinsons Foundation Center of Excellence here. I've been working in movement disorders for the past 20 years, and so I hope to show you why I love working with these patients. And so today I hope to help you understand who the ideal candidate for DBS surgery is, to show you what programming is like for movement disorders, how remote programming can increase your access to care, and show you how multidisciplinary care is really key for the patient that has DBS or any movement disorder. And then what we have to think about when we are taking care of DBS patients. And so these are my disclosures. I will not be discussing off-label use of devices today. And so as you should know, if you have Parkinson's or essential tremor or dystonia, a movement disorder is a neurological condition that can affect the speed, fluency, quality, and ease of movement. The diagnosis is of history and physical exam. So there's no blood test or scan that can really diagnose a patient with a movement disorder. It's really by history and exam. And so there are disorders that have slowness of movement, which is a Parkinson's disease, and there are disorders that have extra movements like essential tremor and dystonia. And so the diseases that we can treat with deep brain stimulation are Parkinson's, essential tremor, and dystonia. And the other disorders that are approved for deep brain stimulation are OCD and epilepsy, but I won't be discussing those during this talk. So Deep brain stimulation. I'm not sure how many people know much about it or have it already. Maybe if you can put that in the chat, if you already have deep brain stimulation, that would be helpful for us to know. So in deep brain stimulation, there's an electrode that's placed in the brain and by a surgeon, and that electrode is connected by an extension wire to a battery in the chest. And so that electrode we can program as a programmer to send electrical impulses to treat symptoms of movement disorders like tremor, rigidity, slowness of movement, dyskinesia, dystonia. So as you can see, we can choose many different contact configuration. Each one of these pieces on the electrode that are lighting up are called contacts. And so choosing the contacts is one of the variables that we can change. And so we have a programmer that sends stimulation pulses up to the brain, and we can control those pulses to really help fine tune the settings for each of the disorders that we see in movement disorders. So as you may know, DBS is an implantable system that modulates brain activity to improve motor symptoms of movement disorders. And so that's just a fancy way of saying that we don't know how DBS works. And so what we think is happening is that there are some abnormal frequencies in the brain, like the nerve cells are kind of just firing at different frequencies. And when we introduce stimulation, we are giving a more normal pattern. And that is how we are renormalizing patients' movements. And so we don't really know the mechanism of action in DBS. And so there are several advantages to deep brain stimulation. It's adjustable, so we can change the settings, and there are hundreds of thousands of settings that we can use that would work for a patient that has a movement disorder. We can do the stimulation bilaterally. In the past, patients have had ablation procedures where the area of the brain that was causing a movement disorder was actually damaged, like burned or frozen. And those kinds of procedures you can only do on one side, because if you had them on both sides, you would have side effects like changes in speech. So with deep brain stimulation, we do not cause damage to the brain, so we can do the surgery on both sides. Each patient has a very different disease process and very different symptoms. There are no two patients that are exactly the same, so we need to individualize or personalize settings for each patient. Also, in the future, when we find the cure for ET, PD, or dystonia, we can turn off these batteries, we can take them out, we can pull out the electrodes from the brain, and the brain is intact for whatever treatments we have available to us at that time. There are some disadvantages to DBS. So there can be surgical complications, there can be a bleed in the brain, there can be infections at the surgical sites. Device complications, these are man-made devices, so we can actually cause, that they can malfunction, the batteries need to be replaced every so often, and that needs surgery again. There are stimulation-related complications where if we give too much stimulation, we can actually cause numbness and tingling, we can cause more dystonia, we can cause speech problems or gait problems, but the beauty of deep brain stimulation is that we can reverse those side effects by changing the settings. And so being adjustable is really the beauty of DBS. And so DBS has been approved since '97 for tremor and PD and ET. It was approved for PD in 2002 and for dystonia in 2003. And so it's been around and FDA approved for many years. Each movement disorder has a different target and very different settings. So you may have heard these terms. In PD, we use stimulation of the STN, the subthalamic nucleus, or the GPI. And I'm not to show you scary pictures, but these pictures are just schematic diagrams of what these structures are around the STN or the subthalamic nucleus. And you can see how the programmer really needs to avoid some areas that might cause problems like depression or muscle contractions, but also how difficult the surgeon's job is to put the electrode in the right place. And so in essential tremor, the thalamus, or the ventral intermediate portion of the thalamus, is the target. And then in dystonia, the target is really the GPI, or the globus pallidus. And so you can see the electrode is in the middle, and there are many structures around it. So as a programmer, we need to know what symptoms we can cause with overstimulation, and what symptoms we're treating. And so the most frequent question I get is, how successful is deep brain stimulation? And DBS is really a success when you have a multidisciplinary team effort, when the right candidate is chosen, when that candidate has realistic expectations and works with an experienced team and has really great continuity of care. And so the realistic expectations that we really strive to educate patients about are that DBS is not a cure. We don't expect every patient to have the same results. Everyone is different. So the optimal results are going to be different for each patient and take time. At the same time, as we increase stimulation, we lower medications. And so it's really a process. It can take a few months for us to get to the right settings. And particularly in Parkinson's disease, what we see as your response to levodopa or Sinemet is what we'll see in as your response to deep brain stimulation. So before we even have surgery, we will do a levodopa challenge for patients that have Parkinson's, and whatever your response is to levodopa is what your response is going to be after deep brain stimulation surgery. And so most centers have a DBS team that evaluates patients for deep brain stimulation surgery. And so each patient that is considering surgery really is seen by a neurologist, a neurosurgeon. They see a neuropsychologist to evaluate their cognition or their memory. Sometimes we have a psychiatrist evaluate a patient's mood before surgery and after. Many centers use PT and speech. Most experienced DBS centers have DBS rounds where we speak as a team, a multidisciplinary team, where we have neurology, neurosurgery, neuropsychology, psychiatry. We all work together and listen to each patient's case, and then we try to decide what would be best for that patient. And also patient education is key. So I actually run a DBS information session every couple months to help answer questions that patients might have. So in Parkinson's, deep brain stimulation treats tremor, rigidity, bradykinesia or slowness of movement. Motor fluctuations are these on-off periods that patients might have. Dyskinesia are the extra movements from medication. Dystonia, and off medication times. And so there have been multiple studies looking at DBS and after, before and after deep brain stimulation. So you see on the left here, the blue area on the bottom of the graph is when patients are off. The green area is when patients have quality on time, and the red area is on time but with extra movements or dyskinesia. And so on the bottom you see arrows where the patient actually took medication. And so before medication, the patients were really immobile, and then they took medication. It took a while for it to kick in, but they were doing well. And then at the peak dose, the patient is in the red zone with extra movements, and then the medication wears off, and the patient takes another dose of medicine, and they go back up into this on time with dyskinesia. And so these on-off fluctuations before surgery can be really debilitating. But on the right, after surgery, you can see that the patients are still taking their meds, but they never get back down into this blue off period, and they don't reach this red area with extra movements or dyskinesia. They're really maintained in this green quality on time with medication and stimulation together. And so this study is older, but 5-year experience showed that patients had maintains their response to stimulation with improvement in tremor, rigidity, and akinesia or bradykinesia, which is slowness of movement. And then also, in my experience, after 20 years, patients still have good response to tremor, rigidity, and bradykinesia. Also, this was a trial that looked at patients that were separated into two different groups. There was a group that had patients that only had best medical therapy in blue, and a group that had patients that only had deep brain stimulation in red. And you can see on the top that the patients that had neurostimulation in red had greater improvement in their quality of life scores. And on the bottom, all of their ADL scores were they had much greater improvement in their activities of daily living. So as compared to the patients that had best medication therapy only. So these are just studies that show that deep brain stimulation can really help patients' quality of life. Now, deep brain stimulation does not help cognition, speech, mood, gait, or postural instability. And so we really need to counsel patients that we might not be able to help everything. What we're really helping are the motor symptoms that patients are having. And a good candidate for PD, deep brain stimulation, is someone who has very good response to levodopa. And the one symptom that doesn't need to respond to levodopa is tremor. And so patients, if they have a tremor that doesn't respond to levodopa, they are still candidates for surgery. Patients need to have at least 4 years of PD and intact cognition. Patients are excluded from surgery if they don't have a response to levodopa except for tremor, if they have dementia, or if they have other comorbidities that might not allow them to have surgery, like cardiac conditions or uncontrolled diabetes. And this is just a video to show you that when you have the right patient, and that patient has well-placed electrodes and a good patient programmer that can get the right setting for them. Once I reach 3 volts for this patient, his tremor just stops. And so that's what I get to see every day. And so this is really why I love deep brain stimulation. So in essential tremor, the ideal candidate is somebody who has debilitating tremor, has tried every medication that we know can help, possibly, and then also does not have dementia. And so I just want to show you this video. This is in the operating room. As you know, ET is a tremor with action. And so when this person is trying to write or hold a cup, the tremor comes out more. And they're trying to draw a spiral. But after the electrode is placed and then they test it in the operating room, the tremor is really gone. And so, and this patient can actually write her name. So it can be really life-changing to have the right patient and a well-placed electrode. And so this patient has essential tremor, and you can see she's got really bad postural tremor before surgery. And then I'm just going to fast forward to her after she has deep brain stimulation. You can see she's got a lot of tremor when she's trying to do things. And here, this is about 3 months after surgery, and she really has no tremor at all. A little bit of tremor sometimes, but essentially she's doing really well from surgery. And so if we have the right patient and well-placed electrodes, we can really do great things. So in dystonia, a patient really is a great candidate if they have primary dystonia, meaning that there's no accident or trauma or lesion in the brain. They have tried many medications and they don't have any dementia. And so just to show you a video of a patient who has generalized dystonia before surgery, she doesn't really have tremor here. I'm going to fast forward to her foot movements because it's really in her legs that you can see the dystonia. So when she tries to do heel-toe movements, you can see this extra movement of her foot is turning in a little bit when she's trying to do heel-toe movements. And when she tries to do it on her left foot, her left leg isn't actually allowing her to do it. So she feels some tension in the leg, and it's really more difficult for her to do the same movement. And this is her trying to walk down the hallway. All her muscle groups are contracting at the same time. And so that's how she walked before surgery. And so she also had a great deal of difficulty writing. And you can see her arm is moving with extra movements. It's called writer's cramp. And so it's very difficult for her to even put the pen on the paper. And then 6 months after surgery, her walking is much better. And you can see her dog walking down the hallway with her. And she can actually put the pen to paper. And then a year later, you can see her foot movements are really normal. And she really has no trouble walking now. And her dog is really happy. So I'm just going to skip this one just for the sake of time. Now, the ultimate goal of surgery is to really place the electrode in the right place. And so this is a post-operative MRI showing the electrodes, and you can see the different levels of contacts that are on the electrode itself. And so during surgery, patients are usually awake for some or all of surgery. Patients are usually off medication, so we can really see how bad those symptoms are. Some centers put one electrode at a time. Other centers put both electrodes at the same time and at the same surgery, and they will test the electrode in the operating room. So like you saw before, the essential tremor patient, we could turn it on and watch the tremor stop in the OR. And typically the extension wire is placed under the skin and the battery is placed in the chest at a separate surgery because that requires general anesthesia. So these are called staged procedures. So as you can see here, the MRI on the left, it's really hard for the surgeon to find the right place to put the electrode. And so this is called micro electrode recording. The surgeon will pass a very thin wire that can listen to each area of the brain, one neuron at a time. And you can see that as it passes through each area, there's different firing rates. And there is a surgeon in Toronto described this process as driving through Europe with your windows open and listening to the languages and knowing what country you're in. And so that was really a great analogy for this. So we can really hear where we are in the operating room and find the right area of the brain. And this is what most centers do now. But there have been many, many advances in DBS technology recently. There's much better MRI imaging with stronger magnets in the radiology suite. So here, the pink arrows are actually pointing to the STN and the GPI and the thalamus, and we can really, really see the structures beautifully in these images. And there's also direct targeting or MRI guided DBS, where a patient is actually in the MRI scanner. They have a very small frame placed on their head, and which is made for that patient. And the surgeon can really see where they're placing the electrode in real time in the MRI scanner. So we can visualize the placement of the electrodes directly. There are 3 DBS devices. This is a device that has multiple batteries. It has directional leads where we can send stimulation in a particular direction, really fine tune stimulation settings for that patient. This device is rechargeable. On the right here is a patient programmer and the clinician programmer that I use in the office. The next device is also has directional leads where we can steer stimulation in a particular direction. This device and the last device are MRI conditional, so patients can have MRIs after surgery under certain conditions. So we can fine tune the settings for each patient using these directional electrodes. And this device in particular is rechargeable only, and patients can use their own patient programmer that's in white here. And the third company is Abbott. This device is Bluetooth enabled. It has upgradable software, meaning that we can, if the company has any updates in their software, we can actually push updates into the battery, so we don't need to change the battery out if there is an update in their software. These electrodes are directional again, so you can see here that in the circle, you can see this line where this contact is actually segmented into thirds, and next to it is a graphic representation of the electrode, and you can see it's numbered 1, 2 ABC, 3 ABC, and then 4. So we can choose each contact individually and really send stimulation in a particular direction to really fine-tune settings for patients. And the newest thing that we have with this device is remote programming, and so I'll be discussing that a little further in a few minutes. So when we're thinking about surgery after surgery, we have many things to consider when we're programming. And so when we do initial programming, patients we need to know what device they have, what their symptoms were before surgery. They need to come in off medicine, but they're instructed to bring their medicines and their patient programmer or controller so that we can teach them how to use them. As a programmer, we need to use a systematic approach and documentation. Documentation is key. We need to know what happened and write these things down so that we know what to use and what not to use. We need to choose the best contacts with the greatest benefit and least amount of side effects. And then we also need to teach patients about what they need to avoid, what they need to do if they have surgery, and what they need to do, how to use their DBS devices. So we have lots of things to cover at an initial programming visit. And then in follow-up, we need to make sure that we look at incisions. We need to reconcile medications, make sure patients are taking the right meds, and if they're lowering meds, looking at side effects. We need to evaluate their symptoms, make changes in their DBS to maximize their benefit and minimize side effects, reinforce realistic expectations, and then refer patients to the multidisciplinary care team. And that means that we send patients to PT, OT, and speech, because we are really trying to maximize the benefit from the surgery, and we can do that as a team. And then more patient education. We need to reassess expectations about surgery, meaning that DBS is not a cure. It takes time. There are symptoms that we can treat and symptoms that we can't treat. So we need to make sure that patients understand what we're trying to work with. And we need to make sure that patients are looking at their wounds, how to use their devices, and how to adjust their medications accordingly. We need to remind patients to notify other providers about their DBS, and the specific contraindications to deep brain stimulation, meaning the things that you cannot have if you have DBS. One is called transcranial magnetic stim, and that is TMS for short. It's using magnetic pulses, so magnets around the head. Is a definite contraindication for deep brain stimulation. Also, there is a procedure called diathermy, where it's used in by oral surgeons, and it's sending stimulation as a pain control. So this stimulation is localized here, but it can travel to the wire and then up to the brain. So patients that have DBS cannot have diathermy. Patients need to know that if they are going to have an MRI, they need to turn off their stimulators and set it to 0. But they can do that by using their patient controller and using MRI mode. Also, if patients are having surgery, their DBS needs to be off, and there is a surgery mode also on the patient programmer or controller. So there are lots of things that we need to teach you about after surgery. So a few words about telemedicine. Telemedicine is really the use of medical information that's exchanged from one site to another. Usually it's electronic, but there are different ways to use telehealth. There's real time or live. There's also a way to use store and forward. So for example, if you have or watching your blood sugars and you are testing your blood sugar, you enter that data and send it to your provider. That is a way to use store and forward. There's remote monitoring, and then also just audio only or phone calls. And so we're using these different modalities to improve patients' health status. And we can also use this with deep brain stimulation. And so asynchronous care is really when we change treatment based on information that's been collected in the past, like using diaries or even blood sugars that you data that you've sent to your doctor. Synchronous is when we make adjustments to treatments in real time, when we see a patient, evaluate them, and make changes according to how they look in the office. And so the newer thing now is where we have limitations to this. We're unable to, in the past, remote programming meant that we would have a local programmer, and then we would talk with them and they could make changes in real time, because we couldn't really see that patient if they were far away from us. Or we preset patient settings so that the patients can make their own changes on their own using their patient programmer or controller. But now, with remote programming, it's also called virtual clinic. We're able to connect to patients directly. We can optimize their therapy, and it's the flexibility that we have is that we're able to connect to a patient when they're home. And this helps us to avoid many things like travel. I have patients that being in New York City, they travel from New York, New Jersey, Connecticut, or upstate. And this allows the patients to stay home. They don't have to sit through traffic, pay for parking, pay for gas or tolls. And it also helps the caregivers when they don't have to also take care, travel and take care of getting the patient to their respective doctor's offices. Many times caregivers need to take the day off to be able to take care, to bring someone to the office. And so it can be really helpful. And this is just a video that I put together. So this is just how to use, this is what a patient would see in the office. I'm just gonna go back. So patients this is what the device looks like. Right above the green bar, it says remote care is off. And so the patient can turn on remote care, and here they turn on remote care. This is what the clinician sees on the clinician programmer. And then the patient starts the visit. So it's you have the choice to start. This is what the patient programmer looks like with the doctor on the programmer. And then on the clinician programmer, the ones that the doctors have in their office, we have the same programming platform that we always use, and we can see our patients, and we can make that picture bigger so we can really see our patients on the screen. So we're actually connecting to our patients in real time using your Wi-Fi. And it's really been a game changer for me. In my practice, I'm able to reach patients that have a real distance between us. But, so for example, I have a patient who lives way upstate, 7 hours away. He says that it only takes them 6 hours to drive here, but I don't believe him. So because Google Maps says it's 7 hours. And so really, I've only seen him twice, and I've been programming him for the past 6 months. And it's really been really helpful. But it's not just helpful for people that live far away. I have patients that live very close to the office. However, they would need to take the day off or take a half day from work. And so it's really convenient for us to connect by Zoom or by through our electronic medical record system. We can have a telemedicine visit and be able to change settings, and they don't need to leave their office. And so it can be helpful for patients that live both near and far. So there are many resources for patients. So here you see on the top right is a booklet from the Parkinsons Foundation that really talks about surgical options for PD patients. And then there is a booklet that just came out on the 15th from the Michael J. Fox Foundation. It's a deep brain stimulation guide for Parkinson's patients. I was lucky enough to be able to help edit this booklet, and it's a really great resource for patients who are thinking about deep brain stimulation. Underneath that is the Aware and Care Kit from the Parkinson's Foundation, and it has a listing of medications that we need to avoid and medications that are safe for patients that have Parkinson's that are in the hospital. And so we always need to make sure that we are testing for making sure that patients understand that they need to watch for infection. They need to make sure that they're looking for signs of stroke right immediately after surgery. They need to monitor their wounds, tell their providers about any abrupt change in their symptoms, and how to use their DBS devices. And then when patients are in the hospital, we need to make sure that the care team avoids missing, omitting, delaying, or substituting the medications in PD. We never want to abruptly stop levodopa, and we need to resume medications when we're able. And so we might need to temporarily stop medications for surgery, but we need to resume whenever we're able. So patients need to know that when you're in the hospital, the DBS might need to be turned off for many tests that we need to do in the hospital, like MRIs, EKGs, EEGs, or EMGs. And then these are all the providers that I work with as a team. I work with, I work in neurology, and so I work with very closely with the neurosurgeon, psychiatry, psychology, neuropsychology, PT, OT, and speech, genetics, counselors, social worker, our researchers, and all of our movement therapists. And so in conclusion, I hope that I've helped you identify the ideal candidate for DBS, a little bit about DBS programming and remote programming, how we work as a team to really give holistic care to the DBS patient, and some of the patient education that we use post-surgery. And so my name is Joan Miravite, and thank you for your attention. And so I'm just going to take a look at the chat and see. I haven't been looking at it, so
that's okay. I've been keeping track of it for you. We actually have had a few questions that's come through, some that's come through to me directly. So one of the questions that came in is after the initial DBS programming sessions to select the best possible electrodes, do you change these electrodes over time or leave them the same over the years and just change the parameters on these initially chosen electrodes?
Right. So, patients will, if the electrode is well placed, we don't need to move the electrode. We just change the parameters, and there are 4 different things that we can change. We can choose the different contacts on the electrode. We can change the amplitude or the amount of energy that's delivered per pulse per second. The number of pulses per second is the frequency, and then the duration of each pulse is the pulse width. And so out of those 4 parameters, there are probably 400,000 or 500,000 different settings that we can try. So there's never a time where I say there's nothing else I can try. So there are a lot of things that we can do for patients, and then over time, especially with PD, PD changes over time, and so we need to we need to be aware of the changes and then make changes accordingly.
And that kind of goes along with another question. They want to know, after you go through that initial mapping, you need to go through that again to find the best electrodes because the disease has changed. So I think what they're meaning is adjustments over time.
Right. So, that initial programming session where we're like it's really a map of what we can use and what would be best for the patient. And that really is still helpful 10, 15 years out. It's really a good it gives us a good understanding of where we can go. And it's really consistent over time. Um, I, so we can just make adjustments according to what the symptoms are that come out as the disease progresses. And so we don't need to change. By and large, the patients that I've been seeing I do have patients I've been seeing for 20 years. If I point this up a little bit, you can see my old programmers up here. Those programmers were from 1999 and 2000, and they take 8D batteries. So we've come a long way from since then. But there are so many things that we can change and adjust to really treat symptoms, even as the disease progresses.
Okay, well, I have a question about, you referenced 20 years. So someone asked, how long does DBS last? One slide showed 5 years, but you said studies have shown up to 20 years.
So that was my experience, was 20 years. I've been programming for 20 years now, but we only have DBS was approved by the FDA in 97, and before that it was being used in Europe, 95, 1996. So we only have that much information. We don't have more than that. So it's really been around for a long time, but we don't have formal studies looking at we don't have any data for more than 20 years. But I can tell you, in my experience, that I have patients that are 20 years out and they still have the same electrode, the same extension wire. It's the batteries that get changed out every few years.
And how long do the batteries last typically?
Typically, the batteries last about 4 or 5 years. The rechargeable devices can last 15 years. So it depends on how much energy we're using for the patient. So 4 or 5 years is average, but if we use really high settings, it might be less than that.
And I'm curious, I know we have somebody that has their question, but it kind of goes along with that. Is there a difference in battery life? I'm just curious, from somebody with essential tremor versus Parkinson's.
So it really depends on how much stimulation we need to use. And so I can't generalize from one to the other, but sometimes we do require very high settings, like for dystonia, and those batteries might not last as long. And so we typically opt to give those patients rechargeable from the beginning. And so we expect to give them higher settings. Also for ET, some patients actually turn off their batteries at night, so the batteries might last longer.
All right, I think Donna Herbert has her hand raised and would like to ask a question.
Yes, it goes along with those other questions I was asking Joan, because my sister has had DBS for 11 years.
Mm-hmm.
And when they do that initial mapping, what I meant is, do you change the contacts that you're using? Or I know the electrodes are placed initially, and that's very important. And then that initial mapping develops the contacts that are best used to hit the areas to control your symptoms.
Mm-hmm.
Do you ever change those contacts?
Absolutely. We try to find the best settings for the patients, and we can change the contacts, the voltage, the frequency, and the pulse width. And so we really keep trying until we find the right settings for people.
Well, I mean, her symptoms change, but basically over time, the contacts that they're using seem to be the same.
Mm-hmm. Yeah, and that can happen. I don't know what happened at the initial programming, but sometimes we're able to use more of the contacts, but sometimes it depends on the placement of the electrode. Sometimes there are contacts that we can't use, and so I don't know the details of her setting.
Yeah, I just wondered if you'd seen that change or stay the same.
For sure, I change all the time.
Okay, thanks.
Depends on the
And
setting.
you're in a position that you've really seen all the devices over the years.
Mhm.
And Vicki was controlled initially with Medtronic's constant voltage.
Mhm.
And then when they switched it, they went to constant current control.
Right.
But she was 10 years on constant voltage control.
Right.
Did you see any changes in patients that had to switch to the new, that they're all migrating to constant current control, and it changed the way that therapy was working?
So in my experience, the constant current versus constant voltage, the effects are the same. It's just the way that we have to think about programming is a little bit different. And so the overall benefit should be the same, even if it's constant current versus constant voltage. So, we have other things that we need to consider when we're using constant current. So you're really advanced.
I am advanced and no one can answer my questions, but you can, Joan. I love your answers.
I hope I answered
Thanks.
your questions. Okay.
That's great. Is there anybody else that wanted to ask a question? I know there's a few that we still have from the chat, but I want to give everyone an opportunity to ask directly if they would like to. So if you would just raise your hand and let us know, we will make sure to call on you. In the meantime, I had a question that came in about if you can explain a little bit about how DBS helps with dyskinesia. So I know people still get a little confused about that. So if you could go into a little bit more of that, that would be helpful.
Sure. So, we actually can, even from early on, we could see that dyskinesia was a symptom that we could actually treat directly with stimulation. And then, so dyskinesia happens when patients are really taking a lot of levodopa and at the peak of their dose, as I showed you before on that graph with the the blue, green, and red areas. The red area was where patients had the extra movements. And so dyskinesia, disc means abnormal and kine means to dance. And so it's these like dancing movements. I always thought that was interesting. So the dyskinesias can be treated with stimulation actually. And then also when we turn on the stimulators, we are able to lower medication. So that also reduces dyskinesias at the same time. So we can treat dyskinesias both with stimulation and by reducing medications overall. Most patients that have PD are able to reduce their meds by like 40 or 50%. So on average, I do have 1 or 2 patients that are more than that, but patients still need to take their meds because they still have PD.
Awesome. Also, I wanted to know from someone, is there an age limit for DBS?
So most centers don't have an age limit across the states because you can be 65 and look like you're 35, but you can also be 80 and look like you're 65. So we have had patients who went through DBS at the age of 80 because they were just so healthy otherwise. And then, it also runs the gamut to like patients that are like 40 who are really in like terrible physical shape that, they need to get better overall. So, we don't have an age limit here in the States typically, but I know in Canada, there's a limit at 70, and sometimes in Europe, they also limit to 70. But here, most centers will really evaluate a patient no matter what age they are.
Okay, and I think Lenore has her hand up and would like to ask a question.
Thank you. I wanted to know about having the head shaved. Do they shave the entire head or partial, or how does that work?
So many surgeons will shave the whole head. Other surgeons will shave just partially, where just in the front where they have to put the electrodes. So it really depends on the surgeon and their experience. So some surgeons like to shave the whole head because it allows for the patient and their caregivers to really monitor the wounds. Other surgeons don't feel like it's necessary to shave the whole head, especially for women who cry when they think about having to shave their whole head like I would. But you know, it really depends on the surgeon's comfort level. So
Thank you.
you're welcome.
Jen, we also had a question come in. They wanted to know when you know the voltage is too high.
So very good question. We have, I do a lot of troubleshooting with my other colleagues here. So when patients have very, you know, a stimulation that's a little bit high, the symptoms that I look for are a little bit of trouble swallowing, a little bit of trouble with speech, a little bit of muscle cramping or dystonia. You know, they can have it in their arm or their foot. So those are just subtle signs that there's a little bit too much stimulation.
Someone, and kind of follow up to that, someone just wrote in, so how can you improve speech and handwriting, which have both gotten worse after DBS using the programming?
So those symptoms are very discrete. So can that patient, can you ask me the question again? I didn't hear. I just want to make sure.
Yes, I think it's a follow-up to the one before. So how can you improve speech and handwriting, which have both gotten worse after DBS using the programming?
I see. So many times if I'm affecting a patient's speech, I can change the settings, so really lower the settings or change the contact configuration, or you know, really change the other parameters. And typically if we're making things worse, it's a little bit too much. So if they are new symptoms, then that to me is a sign that there's a little bit of overstimulation.
Awesome. So I know you had a picture earlier of the surgery and the person was in a frame. So I've heard there's people that do framed and frameless, awake and asleep. Can you talk a little bit about the differences of those, you know, the pros and cons?
Of course. So the majority of surgeons use the frame. It's a big metal frame that allows the surgeon to really localize, like they can really use this frame. It has measurements on it, and so the measurements are really fine to the micrometer, so they can really fine tune where they want to place the tip of the electrode using that frame. And so most surgeons use that. Some surgeons are comfortable using a frameless technology where they get very good imaging a few weeks before surgery. They have these metal markers on that they affix to the skull, and the MRI images are sent to a company that makes a small frame on the head, and then they use that frame instead of keeping a patient kind of bolted to the table. They use this mini frame, and they use a different machine that can help them place the electrode in the right place using this metal plastic frame that's on their head. There's MRI guided DBS where their patients are in the MRI scanner itself. I showed a picture of it before where they have a mini frame, but the surgeon can actually see where they're placing the electrode and stop where they had planned to direct it just by seeing where they are in the MRI suite. And then there was one more. So the MRI guided is actually a sleep DBS. Patients need to be asleep for that surgery.
And is that really based on the surgeon's preference then?
It is. And so, you know, if they are really comfortable doing it, you know, how they've been doing it for 20 years, they're not going to want to change. But there are many surgeons who do multiple ways. And so if they're comfortable doing it, you know, it's really the best surgeons are the ones that do it the most. And so I would recommend to anybody to ask the surgeon how many surgeries they've done and who's on their team, and you know, what they're what they're comfortable doing. So if you're comfortable with that surgeon and that's the way that they usually do surgery, then I would feel comfortable doing it that way.
So we have just a few more minutes. I don't know if anyone would like to have the opportunity to ask Joan directly while you've got her captive audience.
Hi, Dave.
All right, it looks like maybe Marge Infield wanted to ask a question.
Yes, I have the kind that you said, the Abbott that you said can be updated. How often do updates come out?
So not that often, but you know, with anything that needs FDA approval, nothing is fast. So, but you know, when they do update, they would definitely reach out to you. They'll let you know, and then you would probably also work with your doctor to get that update. So not often, but
Thank you.
And I think Dave Orlowski had a question.
Yeah, hi, Joan. I'm just curious. You insert the electrodes into the brain. What keeps them in place? I mean, can like head trauma cause them to move, or like if you bang you fell on your head, hit your head, or something like that?
right,
Did they ever move? What? The brain is basically soft tissue, right?
right. It's
So
great,
I mean,
great question.
what keeps them in place? What keeps them locked in?
So there is actually what we call a burr hole cap. It's it locks the electrode in place. So there's a hole is drilled in the skull, and so the bone is shaved away basically, and then there's a cap. It's like a ring, and then a cap is screwed onto it, and so that holds the electrode in place, and so it doesn't move in the brain at all. But if you do hit your head, you know, you can you know, damage the wire, but typically we don't see movement of the electrode.
Thank you.
You're welcome.
Okay, we have time for, I think, probably one or two more questions. Donna has her hand raised again. Go ahead, Donna.
I just had a question for Joan. If she used Medtronic's Percept with BrainSense to do programming, where you can actually see how the programming is affecting your brain signals.
I have. It's pretty cool technology, I have to say. But you know, it's not been around for a long time, but we can actually watch a patient's brain signals or beta waves. And so if a patient has more beta waves, they actually have more Parkinson's symptoms. So as we go up with the stimulation, we can watch those beta waves decrease. And so that's what we're doing when we're watching it in the office.
And has that programming showed you different kind of rules to adjust other people by?
Not yet. We're still learning how to use it. So it's really amazing to be able to see patients' brain waves in the office, but essentially the programming is going to be the same. So
thank you. Yep.
Okay, well, this has been fantastic. We've had a lot of great questions. Joan, you've done a fantastic job, not only of answering these questions so well, but you know, just giving us such a great overview. We're so lucky to have such amazing technology available to our, you know, people out in the community. So I thank you for sharing all of that great information. If everybody would love to give Joan a thank you, I thank all of you for joining, but if we would give Joan the wave of gratitude and just thank her for this excellent presentation. Thank you, Joan. I don't know if you have any last words for the crowd to share.
Thank you for your attention, and thank you for all the great questions. It means that you are actually listening to me. So no, but I really thank you for logging on, and I hope you guys learned something today.
Absolutely, and they loved your technology using the Prezi format, so it was really fun. Something different. So, all right. Thanks everyone for joining us today. And Joan, again, thank you so much for your expertise and your time. I hope you all have a wonderful rest of your day. Thank you.
Bye.
Bye.